Hello, everyone. My name is Keith Knabb, and I really appreciate being here today. The things that other people don't like to do, I like to do. So I don't mind being called a Medicare nerd. Somebody needs to be. I need a CPA. He's my tax nerd. The rock star in financial services is Kevin, of course. I'm not going to call him a nerd. He's my friend. And I also remember when Kevin was cool in college. I do remember those days. This talk today on Medicare is not necessarily about the beginner's guide to Medicare. It's about how to manage your Medicare. And the importance of managing it means that you're not setting it and forgetting it. You're paying attention. Medicare has changed and it keeps changing. We know what's coming up on a few more years from now. We know what's happened over the last 10 years. The big idea is don't set it and forget it. That's the same thing with your finances, the same thing with your home and auto insurance. You need to review these things to make sure that you're not wasting money, making sure you're taking advantage of all the things that are available to you properly, and also not making mistakes. So right off the bat, this presentation is for educational purposes only. I, of course, am not employed by Medicare. I always present as a public service and do not take payment for my public speaking. Complete information is available at medicare.gov, the federal website. It is thousands of pages long. You can get lost in there down the rabbit hole, but it is comprehensive, and it is the federal guide to Medicare is there. Today, we're not going to talk about any plan names or companies or prices. We might talk about the blue company, the red company, the green company, but I'm not allowed to talk about their official names. And additional educational flyers, such as the ones that I've given you, are also available up here at the resource desk. But every flyer that we have is also available at our website, amsplans.com. My business card is up here too, but the website is amsplans.com. And all of it's available, including an ebook, a 12-page Medicare booklet that tells about everything we've got here in a summary format, and it's a little bit easier to read than the 150-page book that Medicare mails you every year, right? It's a great starter kit to help people to understand some topics. A lot of times we have adult children that come and say, hey, I don't understand what my mom and dad have. And that 12-page book gets them started as a primer to understanding their parents' benefits. We do a lot of family guidance. So if you have a son or daughter that later on might be helping you, they're going to give us hugs because they don't want to deal with this either. Okay? Here's the deal. In 1965, Medicare was created because seniors didn't have health insurance. They had insurance at work possibly, but when they retired, they didn't have insurance. But also people weren't living that long, so this wasn't intended to be a long-term program at that time. Now people can be on Medicare for 30 years, right? Until they're 95 or 100 years old. But that in 1965 is a long time ago. That's over 50 years ago. And healthcare has changed tremendously. Medicare is a federal program, and it's run by the Centers for Medicare and Medicaid Services. It is not the same as group insurance. Your employer-based insurance is not the same as the VA. It is not the same as Medicaid. Medicaid is for low income, people that have spent down their assets, or some other circumstances. But it is definitely not the same as the Affordable Care Act. And people are calling us saying, I heard on the news that my company is pulling out of Georgia, or that they're not going to serve this hospital, or there's this argument going on. It's not about Medicare. That's about the Affordable Care Act or some other negotiations that might be going on. But generally, the Medicare plans are very stable, and they're not in the news like the Affordable Care Act plans are. So be careful if you hear news that you're not confusing the two issues. And this happens. Every year we get a lot of panicked phone calls, and it's usually confusion based upon that. So the types of eligibility. When Medicare was created, the intent was to give people that have been working and paying taxes for 10 years or their non-working spouses insurance at age 65. So that was the plan. And some people raised their hand and said, wait a minute, what if this person got hurt at the factory and now they're 57 years old, or they got hurt on their farm or wherever? They need some help now. So they created Social Security Disability Income, which is a program that if somebody can't work, that they can get the government to give them some benefits. And if they're on that program for 2 years, they get Medicare. So I have a lot of clients that are 40 years old, 60 years old that are on Medicare because of disability. And then some people raised their hands and said, well, we've got other problems here. We've got people that have Lou Gehrig's disease, or they need a kidney transplant. They need care not 2 years later. They need care now because they'll be dead if they don't get care. So they created a third eligibility that allows people that have those problems to get Medicare very, very quickly. They'll get awarded within a month to 4 months their Medicare, so they can get their dialysis or they can get their medical care that they need. So these types of eligibilities have evolved over time. There have been people in the government that are talking about extending Medicare to spouses that are younger. Maybe one spouse is 65 and one spouse is 60. Those are just political discussions. That has not happened. And I still have people today ask me, hey, my wife's 65 and I'm 63, can't I just buy into Medicare? No. Maybe one day, but not currently today. Any questions about the eligibility? So the foundations of Medicare. The foundations of Medicare are totally different than any other health care plan. And this is where the start of the confusion comes in. So don't feel bad if you get confused on this, because this was created over 50 years ago. 50 years ago, if you were sick, you went to the hospital. You went for exploratory surgery or some testing, and they put you in a bed for 3 or 4 or 5 or 6 days. Hospitalization was the primary mode of care, and Medicare created Part A of Medicare to be dealing with hospitalization and skilled nursing rehabilitation, because that's what people mostly needed for major services. And yet today, more than half of medical care is outpatient. You don't go to the hospital. You go get an MRI. You go get a CAT scan. You get some blood tests done in the doctor's office. Used to be you'd have to wait 3 or 4 days for blood tests to come back. Now you can get it almost instantly, definitely overnight. So outpatient spending of Medicare is more than half of its spending, and there's a premium on the outpatient care. It's called Part B, and there's a $134 a month premium, whereas the hospital portion's free for most people. Part B of Medicare also has a penalty if you have a high income. For an individual at $85,000, for a household income $170,000 or more, you start to pay extra for your Part B outpatient coverage. Now, at this point, is there anybody in this room that is currently still working at an employer and has their Medicare activated? Okay, so if you're working at an employer that's a large employer, you have the employer insurance as your primary coverage. Medicare will be secondary if it's 20 or more employees. So it is an option to either start A or B. You don't have to, and most people don't even start B because it costs a premium. A will coordinate with your group health insurance.
But I'm a 501c3, I'm a small company. So
okay, great, thank you. So that helps, because if you're 19 or fewer, your group employer health plan will become secondary, and you must start Part A and Part B. I have a flyer up here that is for people in that situation that explains those rules. Also explains using health savings accounts when you're on Medicare, which you can't do. Health savings accounts. So this is the foundations. No other health insurance works this way. Today, if you have a health plan at your employer or some Affordable Care Act plan, you have a card. That card is not Part A and Part B. It's just your medical health plan. You use the same card when you go to the hospital, the doctor, the pharmacy. You have a health plan. Medicare was built in a time that health plans weren't around like this. Totally different time period. And they need to fix this, but it's going to take a lot to turn that battleship around. That's a big process, and we'll talk a little bit about that. Okay? So in 2005, finally, after doing discussions from around the year 2000, Congress decided to modernize Medicare. And modernizing Medicare was to get it up to speed, which other health plans, other health systems had already started in the 1980s and 1990s to modernize. But Medicare finally waited till the year 2005 because they saw the baby boomers coming. We had about 35 to 40 million people under Medicare at this time period, and they know that Medicare is going to go to 85 million people on it. And they said, we better fix this before we get overwhelmed with our inefficiency and the fact that we haven't modernized. And so they said, we want to make sure two things happen. We want to improve Medicare, but we don't want to tick seniors off. If you tick seniors off and you're a politician, what happens to you? You get voted out of office, right? The last thing that Congress wants is 35 or 40 million seniors marching on Washington, right, with their burning brooms and golf clubs. They don't want that. And this is really important to compare what happened under the Affordable Care Act, because Medicare said, let's modernize in an optional way, give people options and not force them to change. And let's do it over 20 years, not in a short time period, so we can do this in a long, smooth, and it has been fairly smooth pathway from 2005 to 2025. Let's modernize over time. Whereas the Affordable Care Act was the opposite. From 2010 till 2015, it just went bananas, changing everything, and we've seen a lot of ill effects. We've seen a lot of companies pull out of the markets. The Affordable Care Act has had a huge amount of disruption and problems and doctors' complaints and other things, whereas Medicare has done a nice, smooth transition to modernizing, and we're going to go over those things. But basically, Pathway 1 is the traditional side of Medicare. Pathway 2 would be the modernizing side of Medicare, and I'll describe what that means. Path 1 of Medicare was created so long ago, and the people started using it, and they were glad they had this coverage, and they started complaining to say, well, wait a minute, it doesn't cover everything. This Medicare program's got holes in it. It's got deductibles. It's got things we have to pay that we weren't expecting. And so insurance companies noticed in the 1970s and said, we can fill that need by providing little miniature policies. And a million different ones were created around the United States, and it was super confusing to all the insurance commissioners, to all the consumers. There was a lot of bad sales practices that were happening. So the government stepped in the 1980s, and this was the first time to standardize this health insurance that they nicknamed Medigap plans. Medicare supplements are plans that fill in the gaps of Medicare. Medigap programs, very popular today. We have 14 million people accessing these secondary insurance policies that repair the holes in Medicare. Medicare pays first, and then on top of that, you'll have a supplement. Okay? If you are provided retiree coverage from your retirement program, you may not need to do that. That retiree coverage may be your fix for Medicare. If you're working at a large employer, that employer insurance is what is working with Medicare to fix the holes in Medicare. But if you're on your own purchasing Medicare, you would want to look at these supplements to fix the deductibles that are very high and the 20% that you have to pay on outpatient services. These supplements, though, have a price. They run $150 to $250 per month on average. Depends on the type. There's multiple styles of these supplements. And I've got a sheet up here that explains what those styles are. But they are we'll go over what they cover in just a minute. But that means you have a Part A and B card on the screen, Part A and Part B. That's your Medicare card. Then you're carrying now a secondary insurance card. And then you're carrying today a third card to cover your drugs. No other health system does this. 3 cards that you have to do it. And I have families that come in and say, I don't know what mom has. She's had a stroke. Here's her purse. And they throw all these cards out on the table. Literally just, here, let's figure out what she's got. And we go through and get rid of the discount cards and the CVS and all this stuff and find the 3 valid cards for mom. But the daughters and sons say, well, this is crazy. At work, I have 1 card. What is all this 3 cards? And I have to explain it to them because this is the way Medicare was built over time. So who here carries 3 cards with them? Probably a few of you, right? And so you understand this process, but no other health system does this. and is very popular. I have half of my clients that access Medicare this way. If we compare that to the modernizing system of Medicare, where Medicare said, let's try out HMO plans and PPO plans, I'll define those, plans where we have doctor networks, where we have a single package, we have hospitalization, you have your outpatient, your drugs, and some extra coverages all in one ID card like you did at work. This is the side of Medicare they call the Advantage system, or if you go to the Medicare website, it says Find Health Plans. Medicare refers to these as health plans because instead of being the parts and pieces, it's a single package. And so now it's around 21 million people in Medicare that are accessing their Medicare this way. And it's interesting. There's no right or wrong. We're going to go over the differences, but does anyone here have a plan where you have a Medicare plan where you have a doctor network to choose your doctors? Okay? And you pay a copay to go to those doctors? You know, $10 to the regular doctor or 30 or 40 to the specialist. That means you're utilizing a Medicare plan that has a network called either an HMO, which is a mandatory network, health maintenance organization, but you have to use it unless it's an emergency, then you can go outside the network. Or you can choose a PPO plan, which means it's a preferred provider organization, which is optional. You can either go in-network or out-of-network. So HMO means that you're going to be restricted on the network. PPO means you're a little more flexible. And traditional Medicare would mean no network, just go see doctors that take Medicare. So you have to be aware, and we're going to go over physician selection, but that's a very important part of this system because that's also a very important part of regular group employer-based health insurance, has been for 20 years at least. And everybody's very familiar with that. And oftentimes at work, you would have 2 or 3 choices. They might say, hey, here's an HMO choice, here's a PPO choice. You might have 2 options at work. Well, Medicare has created that same style of system here. And half of our clients deal with this. So half are on that supplement system and half are on Advantage HMOs or PPO systems. If you're on a retiree program with your retirement with IBM or Lockheed or some big retiree program, they may be giving you insurance or they may be giving you options like these through their system to access Medicare, where they're giving you options. Do you want to access Medicare with a PPO or do you want to have an insurance policy? Your retiree systems are evolving right now, and every year in September or October you get your annual notice from your retiree program. You need to read it carefully because a lot of them are having dramatic changes. They're adding options or deleting options. The teachers' retirement system here in Georgia deleted the traditional option and moved all of the teachers' retirees into the PPO options, all the teacher retirees. We're seeing a lot of retiree systems giving their retirees $200 or $300 a month and saying, pick your options you want, but you must use a service that we are providing to you in order to access these monies that we're putting aside for you. It's a weird thing that they're doing to force people to do that. But you need to pay attention because if they're not giving you that option this year, they're probably going to do it next year. The big bell cows like IBM and AT&T and all these big giant corporations have led the way on this. A lot of retiree systems like teachers' retirement and government retiree systems have led the way institutionally, and now we're seeing even smaller employers migrating to this. And that's a big reason financially for it. If they provide a benefit themselves, that is their own health plan, they have to project that out 10 years on their financial reports. But if instead they give you a certain dollar amount each year, they only have to report that as a 1-year liability, and it dramatically affects their stock price. So a lot of companies, and you know this, Kevin, a lot of companies say, wait a minute, if IBM's doing that, look what it's done for them, we're going to do the same thing because it reduces their long-term liabilities. And retiree health care is a dramatic liability, and unions are feeling this quite a bit. If any of you are on a union retirement, unions are feeling a big pinch on retiree health care costs because they didn't project out their numbers correctly. Okay? Any questions? And I'll go to explain what these mean. All right? So people say, all right, Keith, I'm already not sure what you're talking about. Just tell me. I get it. I understand. Tell me how do people make a decision here? How do they decide between those two pathways? And the reason I told you there's two pathways is your neighbor might say, do it this way. And your sister or brother might say, no, do it this way. Well, you have to understand the difference. Sometimes one spouse will choose accessing Medicare one way, and the other spouse will choose it the opposite, a different way. So it's really fairly simple. There's 3 areas. On the left-hand column, it says supplement and advantage, and then it says you can go to any doctor who accepts Medicare nationally if you use traditional Medicare with a supplement. You can pick any doctor that accepts Medicare nationally, but not every doctor is seeing new patients, right? So you have to ask those doctors, are you taking new patients? Because there's quite a few, in certain areas a lot, and around here we're doing pretty well. But if you're under the Advantage, HMO, or PPO, you're first going to look at the network. Is my doctor in the network this year? Well, is my doctor in the network next year? A good time to ask is in October, because if they're going to add or join networks, it's generally about 3 months before the end of the year. If that doctor, if she's selling her practice, well, maybe she's joining Emory Physicians Group. Well, what does Emory Physicians Group take? She might not have taken some plans, but now she's sold her private practice, and now she's got into this larger practice. What plans do they accept? So as doctors are changing, you have to ask them, hey, is my plan, are you going to be on my plan? Are my choices changing? The middle column says, what are you going to spend to own your insurance plan? Are you going to pay per month $150 or $200 a month plus a prescription drug plan? And that's husband and then also wife. So you might be looking at $400 or $500 a month to own the plan. Or when you do the HMO or PPOs, if you've ever seen the advertisements, some of them are $0 per month. We can't say free because the government is paying the companies to take care of you, but it's a 0 premium or maybe $30 or $40 per month. Very affordable premiums. So the monthly cost is a big difference, but the reason the monthly cost is a big difference is your difference of what it's going to cost you to get better if you're sick. If you need a new hip, if you need to go to the hospital. When you're under the first style, the supplement style, you're paying the money to the insurance company for them to promise you, hey, we're going to pick up your bills if you get sick. If you give us $200 a month, if you go to the hospital and have a bunch of bills, we're going to cover those for you, possibly up to 100% of your bills. Whereas when you're on the HMO or PPO plans, you're going to be paying copays. Like I said, $10 to the regular doctor, $40 to the specialist, $80 or $90 next year to the emergency room, maybe $300 a day to the hospital. So that same hip surgery that could be free, I've heard people say my hip was free, my shoulder was free. Though the person over here might say, my hip cost me $500 or $600. Let me compare this, though, to what happened to me last year. I'm under an Affordable Care Act plan, got me a new nose, had an old sports injury. Looks good, doesn't it? And it was a 1-hour simple surgery inside my nose. And it cost me $6,600. $12,000 surgery. I had to pay $6,600 for that. Write a check. Okay? I would have much rather taken a nice cruise around the world. Up here, I could have said, I've got a free nose. Down here, that nose would have cost me about $300, maybe $500 on a bad day. So I would much rather have one of these two options than my cruddy Affordable Care Act plan where I have to pay $6,600 to get my nose fixed. And so what are people doing that are 60 and 64 years old? They're like, oh, I'll just wait and get my shoulder fixed when I get on Medicare because I can get it done for free. Or I can get it done at a low cost. People ask me those questions. Say, Keith, I need a new knee. Should I do it now or should I wait till I'm 65? We have those conversations. And Medicare is feeling that pinch right now where people are waiting until they get on Medicare to do these services. And a lot of you have been on Medicare for a while. Have you ever had a surgery and you've gotten home and you realized you never got a bill for anything? Did that happen to any of you? Or stuff was free, okay? Kind of neat, but you had paid for years to have that privilege. If you paid $2,500 a year for 5 years, that's $12,500 that you've given to an insurance company to fulfill the promise that your nose will be free, right? So it's not right or wrong. It's, do I want to prepay for my care, or do I want to pay as I go along? This is very much like Clark Howard talks all the time, if you like Clark like I do. And it's really important. You can prepay for things. You can buy a warranty and get a free refrigerator, or you can wait till the refrigerator dies and get it repaired or a new one. I've never had to buy a new refrigerator. I've always had one at the next house that I went to. My brother bought a timeshare. Did he get to go free on vacation every year? No, he prepaid for that vacation, right? And what did that $25,000 payment cost him, Kevin? Was it $1 million it cost him? Probably. Prepaying for something that maybe he should have shopped every year for. But it's really a choice. Do you want to pay now or pay later? That's really what it comes down to. And it's really important in your financial decisions that you don't overlook a few things that we'll go over in just a minute. But on the sheet that I handed out to you all, the one that says verses, do you see the sheet that says, see, that's what I'm thinking. I don't think it made it around to you guys. There's a sheet that says verses at the top. Okay. Yep, that one. Hand that around to them. Yep. Okay. Yep, you'll get it. I'll get it. We'll get it. We'll get it for you. They're bringing it around. Okay. Sorry about that. So the sheet that says verses breaks it down on one page, original Medicare versus modernized Medicare, because I'm not giving you a test after this class, okay? Make sure they have some up here. I know you're not going to remember all of this, but on one piece of paper, it basically shows you the differences between the two things that I've just told you. On one sheet, it tells you about your drug plan, about your doctors, but it doesn't, some other things we're going to go over in just one second, the extra coverages, and also star ratings. So star ratings mean, is this a quality plan? If you're under Medicare and you have a Medicare HMO or PPO or a Medicare drug program, the companies are required to tell you every year in October or November their star rating. If they are a 1 or 2 star rated plan, they hate this rule, but they are required to let you know that they're cruddy. They're required to say, we're really bad and you got to know about it. Well, every plan would love to be a 3 or 4 star plan. About 75% of plans today are in that average to above average range. In Georgia and Atlanta especially, we're very lucky. We have a lot of plans that are 4 and 4.5 stars, which means they're really paying attention to their P's and Q's. They're rated on clinical measures objectively. It's a pretty good system. It could be fine-tuned a little bit more, but it is very difficult to become a 5-star rated plan, and that's the way it should be. Because when a plan is a 5-star rated plan, they get extra privileges and extra things. They get a big bonus monthly from Medicare per person that they're serving if they're a 5-star plan. 2 times in the last 12 years, we've had 1 5-star plan. Around 2010 and now this past year in 2018, this past 9 months, 1 plan in Georgia has been a 5-star rated plan. And they didn't even know it, expect that they were even going to get it. It was like almost an accident. They're like, wow, we were a 5-star plan. They served a very small population of people, and yet they hit every star and they got a 5-star. They're like, wow. Yes, sir. Are these companies re-rated every year? Yep, re-rated every year. It comes out, unfortunately, in like November is typically when it comes out, and it is published on the Medicare website. But if a company sends you any information, they are required to show you their current star rating. They can't tell you, hey, next year we're going to be 4.5 stars. They don't know. They have to show you their current star rating. Now, if a company, yes, ma'am. The government, the Centers for Medicare and Medicaid Services. And it is objective, not subjective. They are true, measures they can actually be measured upon. Clinical measures, how much preventive care, how much immunizations, how much hospital readmissions, it's documented things, okay? When a company gets a 3 or 4 star rating, they get a bonus from Medicare for their good performance. If they get a 1 or 2 star rating, they get a deduction. So all the companies that are 1 or 2 star rated, whoever's running those companies are getting probably demoted or fired because the companies are going to lose money, right? Or they're going to get sold, purchased, something like that. So very few of the companies are getting 1 or 2 stars. Most are in that 3 and 4 star rating. And then if they get the 5-star rating, that's just spectacular, okay? And as you go up the star rating, these companies get better bonuses. So it's a little bit confusing for the consumer, because if a plan says, hey, we cost $50 per month, and another plan costs $0 per month, you might think, hey, the $50 a month plan must be better. If I go to buy tires and it's a $80 tire versus a $50 tire, it's probably a better tire. That's not the way it works here. Because if a plan is a $0 per month plan, it may have gotten a $50 per month bonus from Medicare for being a 4.5 or 5-star plan. And they might say, we don't need to charge a premium this year because we got a bonus. So you can't, as a consumer, you can't tie price to quality. I know that's confusing, but I just gave you the warning, okay? Look at the star rating, not the price. Okay, that's one of your first signals. Now, Medicare also was way behind the times and did not create prescription drug coverage under Medicare until 2005. Think now of your parents and other people when they were in the year 2000 and they had drug bills, they were paying that out of their pocket. Can you imagine today, right? You hear about the cost of prescription drugs today. It's crazy, right? We've luckily gone to about 80% or 85% being generics. So if you're on generics, that helps. But there's a lot of drugs that are expensive. And Medicare finally in 2005 created a drug benefit. But since they were so far behind the time of creating that, they were very worried of how many people were going to access this benefit and was it going to sink the federal budget. So they said, all right, what if we gave everybody generic drugs at this price and brand name drugs at a higher price? And the Congressional Budget Office said, sure, let's see what that'll cost. And they calculated it at trillions of dollars. And so the congressman on the committee said, well, we can't put that through. So the Congressional Budget Office basically said, tell us what your really goals are. We'll try to see if we can massage this and make this work. They said, we want to give everybody something up front so that they feel they have a worthwhile plan. But we also want to give everybody an umbrella of coverage so that they don't lose their house and their car and their dog to their drug prices. And so the initial bucket of money is called your initial coverage period. Back then, it was around $2,700. Today, it's $3,800 of initial yearly amount of money you get to spend. I'll go over this on the next screen. And then everybody has an umbrella of coverage. But between that initial coverage and that umbrella, it left a big hole in the middle that became nicknamed the donut hole. And we were talking about some people have a real struggle in the donut hole. Well, the one portion of the Affordable Care Act that improved Medicare was closing the donut hole. Again, not in 1 year's time, but over 10 years' time, starting in 2011 to 2021. They are shrinking this hole that was in between the initial bucket of money you receive under your Medicare drug program and the umbrella of coverage in case you have catastrophic needs. They've closed that, and eventually it'll be almost gone. Well, this year, it's very, very good coverage, and people that are struggling in the donut hole is not usually because of the donut hole. It's usually more because they don't understand how to use their drug benefit and how to shop properly for the right drug plan. So we're going to go over that, and I'll show you before, because if I showed you this screen first, you might get cross-eyed. But remember, Medicare created this to protect and put a lot of brakes and limits in to make sure the spending wouldn't be out of control. The Medicare Drug Benefit Program has come in under budget every year of its existence. I think that's the only federal program in the history of mankind that's come in under budget every year of its existence. And yet we still have people complaining, and the drug prices are crazy, and the drug companies are doing things that need to be fixed. But it has come in under budget. This next year, the initial bucket of money people will receive to spend on their drugs is $3,820. A plan can have a deductible, most don't, of $415. That's what Medicare allows. But most either have lower than that or no deductible. But this is really important. The $3,820 is important. That's just over $300 per month, right? About $320 per month. One drug can cost $320 a month, right? If you've been on, Xarelto or Pradaxa or something like that, those drugs can eat up that benefit, and you add other drugs in there, and now you've gone into this donut hole. Well, it used to be that you'd have to pay 100% of your drug, and people were walking away from the pharmacy counter saying, I can't afford $300 for that drug. I'm just not going to take it. And so what happens if people don't take their drugs? They go into the hospital. They end up, their blood pressure goes crazy. They get a diabetic coma. Whatever it is worse than paying for that drug. So the government knew this was actually shooting themselves in the foot, people walking away from the pharmacy counter. Walmart saw the problem first, though. Walmart saw it, heard about it, and they designed a program to give people drugs, generic drugs, cheaply. You've probably heard of the Walmart $4 and $10 program, right? And a lot of your employer plans have these programs, Publix, Kroger. Everybody followed suit with some sort of help for seniors, but Walmart pioneered it. They tested it in Tampa for 3 months. It was such a huge hit that they rolled it out nationwide. And Walmart's very smart. They're not going to lose money on purpose. Okay? And they did the things like my Walmart. They moved the pharmacy from the front of the store to the middle of the store. So they might lose $1 billion a year on their pharmacy program, but they're making $2 billion a year selling you other things, right? Expensive lipstick, $5 worth of Band-Aids, toothbrushes, I don't know why they cost $5. But they know that. They know the process. And the government finally now is caught up, because that was in around 2008, 2010 when Walmart created that. I think it was 2008. And the government now said, well, we're going to close this. And so you have decent coverage now during the donut hole, so much so that when I do drug reports for people, sometimes I see their drug costs go down instead of up during the donut hole. I know it's strange, but we get surprised by a lot of things these days. If you do have catastrophic drug expenses, your worst case out of pocket is $5,100 for the drugs. That's separate from your medical care. And then you would go to that catastrophic umbrella, which means the government will pay for 95% of your drug cost. So I have people that, will have a $10,000 a month drug. It's not uncommon. I have one that has a $30,000 a month drug. But $10,000 a month drug, a life-saving drug, and they'll pay $500 for it. They'll pay 5%. Okay? That's better than paying that. If you have a $1,000 drug, pay $50 for it. So this is very important. But if you're low income, if someone is low income, they get to skip all of this rigmarole and go right to the bonus round. Low income people don't have to worry about all of that. The government subsidizes it and puts them right away into that low cost, where the most they'll pay is around $3 for generic drugs and about $9 for brand name drugs. The sheet that I've given you that says Medicare changes to take effect in 2019 show you where the donut is with the icing on the donut. It shows you the exact costs on that sheet. And if you really are a nerd like me, if you read the back, you can read the actual description of everything, but we're not going to go over that because I'd have to hand out blankets and pillows because you will fall asleep. All right. Now, let's talk about this. Anybody have questions about this? Isn't this crazy? This is the government designing, or a committee designing a horse, right? When a committee designs a horse, you get a giraffe, right? So they designed all of these things, and it's starting to evolve so that it won't be as confusing. But this did come in under budget every year so far, and it is working pretty well. Yes, ma'am.
What is the percentage of people on Medicare that are on drugs? In other words, percentage-wise, I mean, if they're coming in under budget, what is the actual percentage of people?
I think it's 80% have taken a prescription drug program that don't have alternate coverage. If you have VA coverage, that's alternate coverage. If you have employer-based coverage, that's alternate coverage, right? If you get Medicaid, they automatically assign you a drug program. So of the people that are eligible, I believe it's 80% uptake. My mom doesn't take any drugs. She's like, why do I need a drug program? I'm like, because she's got horses, you've got a farm, you can get an infection, you can get broken bones or whatever. You're going to need something, right? The least expensive drug program in Georgia has been always running somewhere under $20 per month, even sometimes less than $15. So it's not unaffordable. But if somebody is low income, the government will pay for their drug program for them. They don't have to pay the monthly premium, and they may also reduce the cost of their drugs down very low. So if you know someone that's struggling with their drug prices, they need to call Social Security and apply for extra help. It's important. And they may have applied 2 years ago and gotten turned down, but their financial situation may have changed over these past 2 years, and now they would qualify. They can apply every month, every year, whatever, until they can find out if they are approved. Okay? So let's talk about what you need to do as a consumer. I don't anticipate we have low-income people in here, but you have drug costs in here. And what you need to do is manage your drug costs, because about 20% of people hit the donut hole, but only about 10% should. It's because people don't know how to manage their prescription costs under Medicare. They don't understand the rules. Okay? So under Medicare, it's really fairly simple. And we have a 10-step guide. We have a YouTube channel, a flyer up here. Tells you a 58-second video if you want to watch a video on how to do this. But it's really simple. You go to Medicare.gov if you have a prescription drug program or need one. You put in your county and your zip code. It's right here on the flyer. You don't have to write all this down. You can come get the flyer. And then you hit go, and it says, all right, put in your favorite pharmacy, okay, CVS. Put in your list of drugs. You put in your 4 or 5 drugs, and you hit go, and in 1 second it tells you, hey, there are 24 drug plans in DeKalb County. And you're like, yes. I get to look at 24 drug plans, right? How exciting. Don't need to play with the grandkids. Don't have to cut the grass. I get to look at 24 drug plans. No. It says, don't worry, 18 or 19 of these plans don't cover your drugs or your pharmacy or both. So don't even look at them. Here's the 5 or 6 plans you need to look at. So it narrows it down real quick, right? Looks at all the plans for you. It's an engine, a digital engine. I use it every day. And yet, this is what will happen. The number 1 plan, it'll say your drugs are covered next year for $450. And you'll go down to the number 5 plan that covers your pharmacy, covers your drugs, and it'll be $1,450, $1,000 difference. But the plan would tell you, yeah, we cover your drugs and we cover your pharmacist. And you're on that plan, and you call them and say, hey, am I okay next year for 2019? Do you guys still cover my pharmacy? Is it still preferred? And you cover my drugs? Yeah, okay, good. You're set, Mrs. Johnson. And they don't tell you that there's a plan that'll save you $1,000. I see it every day. The average error, according to Medicare, is between $600 to $720 per year per person. It is amazing, and this is how it happens. I see it every day. This is how it happens. A person gets on a plan, and it's $20 per month. They don't read their annual notice, and they find out next year in January their plan went up to $50. They're like, Keith, my plan went from $20 to $50. And I said, yeah, I sent you a letter. They sent you a letter. I sent you a letter. We needed to review your plan and find you a different one. Oh, I threw that in the trash. Well, you're stuck on that plan for a year, so you've just wasted $30 a month. That's $360. Then they call me a week later and say, Keith, my drugs went from $20 to $40. And I say, yeah, that's your drug copays went up. I sent you a letter. We were supposed to do your review and find you a better drug plan. That's another $240. You add that together, that's $360 plus $240. That's $600 of waste. And you're stuck on that plan because you have to fix this before December 7th every year. I'm going to go over those time periods in this upcoming screen. But this is when people set it and forget it, they get burned. And the companies know people aren't paying attention. It is around 90% of seniors, 87% to be exact, that don't do this exercise, or they do it incorrectly. They call their company, hey, Blue Company, are my drugs covered? Are my pharmacists covered? Yes, you're fine. That is the wrong question. You have to do it the right way. But what if your plan still says your drug's covered, but you're like, wait a minute, they want to charge me $40 for this drug. I saw one this morning. I was working with one of my agents before I left the office. There was a drug called tizanidine. Anybody ever taken that drug? It's just a cheap drug. It's like $13 a month. And on the drug plans, it was showing $100 to $200 for this drug. I'm like, that's crazy. We went on to GoodRx. It's an app you can put on your phone or a website you can go to, GoodRx.com. And we put in the zip code, we put in the drug, and a 90-day supply was $16 for that drug. And I told the man, I said, your drug plan's fine on these 4 drugs, but that one drug, you need to use this GoodRx and buy it. The Senate unanimously passed yesterday, I believe it was yesterday, I read the article, it said that they passed eliminating Gag Clauses. Some of the insurance companies were putting in their contracts with the pharmacies a Gag clause that says you cannot tell people that if you have a drug cheaper for cash than our plan. Isn't that crazy? Congress had to just pass a rule that says the companies can't put in those gag clauses. That is nuts. The pharmacist is not allowed to tell you, if you'll just ask me, I got this drug for $16 instead of $200. That's ridiculous, because people will walk away. They'll think, I can't get it cheap. The pharmacist's job is to keep you alive and help you save money, in my book, and they were preventing the pharmacists from doing their jobs. Well, that's being fixed right now. Okay? Now, yes?
So, back up for a moment. You said there's a place to review these plans?
Yep. Right on Medicare.gov. This red sheet shows you, yeah, it's right up here on the resource table. And Medicare.gov, right on the main page, it says find health plans, find drug plans. Little green button. Very simple. Yes, ma'am. Okay.
What do you recommend for, like my husband has, his blood pressure medicine, but for me, I don't really take anything right now. So what would you do?
If you're required, you don't have alternate coverage through your employer, you need to buy one of the lesser expensive drug programs, because you don't know what's going to happen tomorrow. I had a friend that went in for a surgery into Emory and got an infection, and things happen. You don't know what tomorrow is going to hold. And $1,000 a month on an antibiotic is no fun. Yes.
The third thing is you also have to know your pharmacist.
That's right.
I mean, I went in and I gave him a prescription for a cream.
Mm-hmm.
And he said, "Are you sure you really want?" He said, "I don't have this."
Uh-huh.
And it's $278. But the paste, what do you call it? Opposite of cream, it's like a Vaseline.
Gel or something?
Yeah, it's $17.
Okay.
But I need to get a different prescription.
Yep.
So I said, "Well, you call the doctor, and off I went."
So his example was the pharmacist will give alternate suggestions, right? There's other things that happen also, but if you're using multiple pharmacists, they might not know what's going on. So if you do buy some drugs from one pharmacy and another one, I don't recommend that, but you better tell every pharmacist what drugs you're taking. Their job is to keep you alive. That's their primary job, right? And the secondary job is to keep their license, right? in their job. The other things that happen is that the drug companies will put a coating on a drug and make it extended release. And it'll be $150 a month for this drug, but if you take it 2 or 3 times a day as other pills, it'll be $8 a month. Just the coating causes it to become a new brand name drug. There's a drug called Namenda that is available as a generic drug, and if you buy it as a generic, it's $34 a month. You have to take it 3 times a day. It's for memory loss. Well, the doctors say, well, that person has memory loss. We want to give them 1 pill a day so they don't forget, right? Well, that's crazy. Somebody's giving that person their drugs at their, breakfast, lunch, and dinner anyway. If you buy the 1 pill a day, it's $334 a month. So that $334 a month wipes out the entire drug benefit, that one drug. But if you would buy it as generic, you're only looking at $360 or $400 for the year for that drug. But the doctor has to have the permission to split it, to get it into generic form. But the pharmacist will tell the families, no, that drug's not available as a generic, because they'll do a slightly different milligram. They'll do 28 milligrams for once a day versus 10 milligrams at every meal. Little tricks. There's another thing that goes on where they'll take 2 older drugs and glue them together. And now you got a new drug. And if you buy the 2 drugs separately, it's $10 a month. But if you put them together, all of a sudden it's this new drug. It's advertised in Better Homes and Gardens, and it says, hey, this is a brand new drug, and it's $400 a month for this drug. It's got special coating and everything. It's just 2 old drugs they've glued together. And so you have to talk to your doctor, because there's a lot of things like that going on. Okay? Very important. Have those discussions. Don't walk away from the pharmacy counter. All right, here's the modern innovations in Medicare. And this is where Medicare needs to save itself, its solvency long term. Right now, Medicare's fine for maybe the next 10 years for sure. I think technology is going to save Medicare for sure, but some things that are going on right now are some no-brainer things that are happening. So let's talk about preventive care. Everybody is not today impressed about preventive care, because we've all basically been getting annual exams for a long time. At our employers or wherever, you would just go get your annual well check. But Medicare didn't cover preventive care for everybody under Medicare until 2011. But in 2005, they tested it first under the HMOs and PPOs of Medicare. the Advantage system. The government forced them to provide annual checkups for the members to see if it was going to work. And once they studied it for 5 years or 6 years, they said, we're going to give everybody in Medicare annual preventive services and immunizations. There's a whole guide to preventive care on the Medicare website. I think it's around 27 items you get. Stop smoking treatment, obesity treatments, all sorts of things. But it was tested first under the modernized side of Medicare and then rolled out to the rest of Medicare. Well, some other things that are interesting right now, discussions that are going on, under the middle area here, you see it says dental, vision, and hearing. Medicare doesn't cover dental, vision, and hearing. Now, if you have glaucoma, that's a medical problem. But if you just need to get your eyes checked for a pair of glasses, Medicare doesn't cover that. If you have macular degeneration, Medicare covers that as a medical problem. But just to go get a routine eye exam and a pair of glasses, Medicare doesn't. But half of glaucoma is found in a routine exam. Why shouldn't we be giving out a $30 exam to find stuff early? Because now glaucoma is treated with the $10 a month eye drops. But if you wait a long time, it's a lot more complicated. Well, the next thing is dental. There's a big discussion about dental. People with periodontal disease, I read a great article this week with people that will have IBS, irritable bowel syndrome. They'll have other chronic health problems, and they'll get their periodontal disease fixed, and all their other health problems dissipate. If you have oral cancer, it can get caught in a routine dental exam. So a lot of the modern Medicare plans, the HMOs and PPOs, are providing annual dental checkups, or maybe even dentures, or maybe some extra dental care, especially for high-risk people. Hearing loss is often untreated for 10 years delay. So if you can give people a hearing exam, and also some of the plans, not every plan, will give out hearing aids or a low-cost price for hearing aids. And hearing loss, if it's untreated, now it's found, they're finding will cause the brain to shrink. Brain shrinkage from not activating the brain. So there's problems. But those things are great. And one of the fun things under Medicare that's happened, the private companies have been giving out some free gym memberships, not Medicare. Has anyone here got Silver Sneakers or Silver and Fit gym programs? Do you use it? Okay, but it's there. The people that use it have a 30% reduction in their medical cost. Medicare doesn't provide free gym memberships, but a lot of the insurance companies subscribe to these services, offer them to their members, and say, hey, go to the gym on us. And the gyms get paid for people to show up. Every time you swipe your card, the gym makes a couple bucks. And a lot of times the retirees are going in the middle of the day, whereas working people go before and after work. Well, the retirees go in the middle of the days. The gyms love it. It's a no-brainer system, and they've tracked it now. It's 30% reduction in medical costs. So I'm not saying Medicare should give out free gym memberships, but the companies are doing some very smart things. But here's what's going to save Medicare is number 3, 5% of people, 5 people out of every 100 people spend half of Medicare's dollars. So Medicare is pioneering a lot of the health plans under Medicare, HMOs and PPOs. The insurance companies are pioneering chronic illness management. And Medicare is paying them to study those populations because they're the ones that are driving the costs in Medicare and Medicaid. If you have 2 or more medical conditions, high blood pressure and diabetes, obesity and diabetes, or heart and lung problems, comorbidities means your numbers go through the roof. They've found that to be a fact. So they're now paying companies extra money and creating special needs programs for these sick people and also low-income people, because oftentimes low income equals low health outcome. And so maybe people need a ride to the doctor. Maybe they need meals delivered to them after a surgery. They're letting the companies experiment with extra benefits. And a big announcement was made this year for these special needs people to even do other things like provide, if the companies want to, not for everybody, but for special needs situations, someone to come into the home and help cook or clean, someone to maybe Uber or Lyft to get them to the doctor more often, maybe to have an air conditioner. If their air conditioner goes out and you got to put a window AC unit in, if they don't have AC, they're not going to sleep, they're not going to be well, they're not going to breathe. And so all of these things, give them a $500 air conditioner instead of a $50,000 hospitalization, right? So they're letting them experiment. Medicare is not doing this itself, but they're looking at all the ways that this will save Medicare long term. But one of the really neat things also for the average person that's not special needs is called care coordination. Care coordination is where hey, I've fallen off my horse, broken my hip, gone to the hospital, gone to rehab, come back home, go to see the therapist. I want to make sure I finish my cycle of care. I'm a healthy person. My mom still rides her horse. She wears a helmet now, a cute bike helmet. But she's going to get hurt. She's going to get stepped on. Something's going to happen to her, even though she's super healthy. I love her to death, but I'm like, Mom, you have to ride the horse. That care coordination makes sure that you're finishing your cycle of care. And a big driver in healthcare is people just saying, I don't want to go. I can't get to the therapist. I can't get to the physical therapy place, and not finishing their care or skipping out on care. So that's a new thing. And a lot of the hospitals are pushing this because they get penalized if people show up a week later after a hospitalization and get readmitted. Hospitals want to prevent people from getting readmitted because they don't want to get penalized from Medicare for that. And the insurance companies also get penalized for that also. If they've been in, it can. So it depends. So Medicare doesn't provide in-home care unless it's maybe wound dressing or somebody for sure is homebound and they can't get somewhere. They can get some limited home health care. Okay? Home care is different than home health care. Home care means assistance with daily living. Home health care means medical care. So Medicare is allowing some of the special needs programs to provide a lot more in-home health care to people who are homebound or won't go to the doctor. But that is not something that Medicare traditionally has done. Medicaid will, if somebody's under Medicaid, they'll get more services towards that. Does that help the question? Okay, all right. So there is a difference, and we'll talk about that again here in the next coming up slides. So now we'll change gears. When would you enroll in Medicare? And we'll talk about the differences. If somebody is retiring at age 65 and they're turning 65 years old, that is a natural enrollment called the initial election period. Or if they become disabled, that'll be their award date when they were disabled and their Medicare card shows up. That's their initial period. Well, not everybody uses their initial period, but that is where I deal with a lot of people that are turning 65 or disabled. Anybody that's also in Medicare gets an annual election between October 15th to December 7th. October 15th to December 7th. The reason they use December 7th is because that gives the insurance companies 3 weeks to approve you and get your ID card so you can start using it on January 1st. But where we're really big heroes for our clients and our resource partners, doctors, nurses, hospitals, social workers, families, is the special election periods. This is where consumers get bad advice and where consumers screw it up and families screw it up. Special election periods, when you're at work, you call them qualifying events. I've gotten married, I've gotten divorced, I've had a baby, those kind of things. I've lost other coverage. Those are qualifying events at work. Under Medicare, it's more like I've moved. I've retired and lost my employer coverage. I'm 70 years old. I've decided to finally retire. I need to activate my Medicare. That's a special retirement election. I have moved into an assisted living home or a nursing home. That's a special period. I had a spouse that was giving me retiree coverage and she died. So now I've lost that coverage. That's a special loss of coverage, special event. We deal with these, and when the consumers deal with them themselves, just like doing your taxes yourself, a lot of times errors get made. When you make a mistake on your taxes, you can amend your taxes and refile it. When you make a mistake under Medicare, you might be stuck with that mistake for the rest of your life. So it's a big difference. Yes, ma'am.
Can I tell you something that happened?
Sure.
In case it happens to someone else.
Okay.
That little last two words there, like moving.
Mm-hmm.
We moved from exit 263 to exit 273 off of 75.
Okay.
It wasn't a nursing home or assisted living. We built a new house. We downsized. It threw us into a nightmare.
Yep.
Of insurance coverage. We found out we didn't have coverage.
They dropped you.
We moved from 10 miles over. So
Yep.
this, in case anyone goes into.
Was it a different county? Is that
Yeah.
why?
Yep.
Different
Yep.
county.
So that's what I was going to add. So let me
We didn't know that.
let me state it. Let me state it for the recording here.
Insurance wasn't even that.
So
We just told them.
The example is you don't have to move across state lines. You could just move down the street. If you leave one county and go to another county, that's typically what happens, and your plan has a service area. They say, we serve these 10 counties, and you leave and go to one outside of those 10 counties, you have lost that coverage, and you better be reading your mail, because they're saying, hey, we've been told you've moved outside of our service area. But no, nothing. Okay.
And of course, it's part of Cobb and part of Cherokee.
That's right.
We had no clue.
Yep.
Anyway, it took us a long time
Yep.
to get that fixed out.
And we would have fixed all that for free for you. So a move is a great opportunity not only to do it right, but when you move, you also get additional rights. So if someone is on an HMO or a PPO, oftentimes this happened. I had a client that was in Tennessee, mom's in Tennessee, the client's here, and he said, mom's moving down from Nashville, and she's got an HMO in Nashville. She's moving here to Atlanta. I said, well, she's going to lose her HMO. Well, what are we going to do, Keith? I said, no, you get to do anything. You get to pick every option because you've lost your other coverage. And you have complete rights, but you have a 60-day window to pick new coverage and to exercise that right. And if they don't notify you, you argue and say, I wasn't notified. And if you haven't told Social Security that you've moved, then you tell Social Security and we can fix things. But why try to figure all this out yourself? That's what my staff does for free. We do all of it and make sure and show you all the options. And a lot of times people are moving because someone's sick. They've had a stroke. They're moving near the kids, right? And so sometimes they say, I was really healthy and all of a sudden I'm in the worst shape of my life. What can I do? How can I legally game the system in my favor? And all the rights and rules are there, but people just don't know how to select and use it. And so that was the gentleman we were dealing with this morning in my office. They were moving from North Carolina down here to Atlanta because his wife's got cancer, getting treatment at Emory. And so that's a special election. If you screw that up, it can be a lifetime of misery of doing it wrong. A newscaster in Atlanta, a retired newscaster in Atlanta, heard me speak at the Cab Medical, and he comes up afterwards and he said, Keith, I did that. I screwed up. I moved mom from Chicago. He goes, I have 2 degrees, 30-year career. I thought I could figure this stuff out, and I moved mom down. I called her company, and I said, what should I do? And he was talking to one division of the company that handled the HMOs and PPOs, and they didn't even tell him he had a right to do a whole other division of the supplements, because that wasn't their job. Their job was to talk about the HMOs and PPOs and only talk about their company. If he would have talked with my office, we would have said, you have every company available to you. You have every option available to you. What does your mother need? Instead, he's calling her company, hey, I want to see what you guys can do for me. That was the wrong way to handle it. Probably cost him $40,000 over the 10 years, about $4,000 a year of error. And he's like, I didn't know. And he goes, I'm an educated guy and probably the smartest guy in the room in most rooms anyway, but or at least he thought he was. So, probably more like it. Yeah. Okay, sure.
Okay, I need a little more specific.
Okay.
So let's say you move.
Okay.
And do I then get 60 days to elect for somebody else, or do I have to wait until the notice comes in the mail? Do I need to?
You can manage the process ahead of time. So there's some
Okay, I get that too, because I'm super organized, so I'm sure I would do that.
but 60 days is right.
That's what so then if I forget to do my 60-day thing, then what happens? I'm stuck for that year?
Right, and you could be accruing penalties. So let's say you lost your drug coverage, and under the drug benefit program, if you go months without coverage, every month that you didn't have alternate coverage and you were left bare, you have about a 30 to 35 cents per month penalty that accrues that becomes lifetime. Also, you may not be able to choose a Medicare supplement with no health questions because you missed that 60-day window, and where if you have a stroke, you don't want to answer any health questions. You just want to have them issue you a policy. But if you waited after the 60 days, they're going to say, tell us your health. What's going on with your life? Do you have cancer? Do you have a stroke? And you're like, yeah, and they're going to say, we don't take you.
Okay. So is it, again, I'm kind of with the 60 days. Is it 60 days after you've moved, or 60 days including when you move, before or after? Like, when does that number start?
Well, it can vary because, and I hate to say this, but sometimes people forget to tell Social Security that they've moved. Okay, sometimes they'll tell the insurance company will cancel them. We can either use the cancellation date or they'll use Social Security. They'll tell Social Security they've moved and that'll create a different date. So sometimes we can massage that, okay? So the right thing to do is to tell your company on the January 2nd that you've moved so that they'll say, okay, we're canceling you January 31st. That gives you a nice month's time to get all the new plans in place for February 1st. And it's not that you're going to lose total coverage. You're going to always have Medicare in the background, but you might lose your HMO or PPO or your supplement or your drug plan. But you're always going to at least have A and B of Medicare in the background as long as you make your premium payments for those, okay? So the problem is that people want to manage this process properly. We got to watch the time. I'm over time right now. But we're almost done. And I'm going to stick around to answer more questions for you. So here's other penalties that can happen. Besides that Part D, the drug penalty I just told you about, Part B, if you screwed that up and don't get it properly, paying the money and doing it right, it's a lifetime penalty. But a common one is COBRA. A lot of times we will have one spouse that's turning 65 and they'll say, well, my husband's 63 and a half, so I'm going to take COBRA for 18 months until he becomes 65, and then we'll both go on Medicare. Well, that's a no-no. Congress is trying to fix that, and you can create a lifetime penalty. So we help people to understand how they can take spouse-only COBRA and let the other spouse go into Medicare, and we educate them on that. And we also educate them on high-income penalties that I described to you earlier. I know you feel like you're experts and that you're going to pass the test, right? But remember, Medicare doesn't cover full dental. Medicare does cover heart attacks and cancer, but there's a lot of other expenses involved in those events. If you have other coverage like Aflac or other things, you should probably keep it. Life insurance, Medicare does not cover to bury you. I've had people say, does it pay for a funeral? No, it doesn't. But the big one is home care. Medicare provides 20 days free and 80 days more, 100 days total of skilled nursing. Medicare does not provide convalescent care. Medicaid does. So you need to have a long-term care insurance policy. If you need to spend $500 a month on your medical care and you don't have a long-term care insurance policy, you are putting your financial life at risk. And you need to talk to Kevin because you need a long-term care policy oftentimes to protect you because going into a care home costs $5,000 a month, at least, if not 6 or 7. Making the wrong Medicare decision might only be a $4,000 or $5,000 per year difference. But the wrong, not having your long-term care needs covered can be hundreds of thousands of dollars of error. So don't assume that Medicare covers those things. Remember, there's a 2 paths to take Medicare. We're seeing 50-50 on those paths, and these government regulations are evolving. We already know in the year 2020 that some changes are coming, and we already have known what has happened, and state and federal regulations are changing. Remember to review your plan every October 15th to December 7th, or when your retiree program sends you the booklet in September or October, open it and read it, and if you don't understand it, call the retiree hotline and have them explain it to you. If they're scheduling meetings for you to go listen to the new retiree benefits, go to those meetings. Don't ignore those materials. It's very important these days. So remember, if you're turning 65, you can start up to 3 months ahead of time. Or if you're going to retire and you know you're going to retire, it's good to start planning 3 months before your retirement date. It takes about a month to get your Medicare stuff set up, your Medicare card, A and B. And then you can start shopping and get the right plans so that when your birthday or your retirement date comes up, you're set and able to use your coverage. But remember, at the end of every year, you want to review it. I can't overemphasize that. That's why I gave you a sheet here that says why annual reviews matter. All of my clients get my staff of 8, soon to be 9, free annual reviews. We're scheduling those right now, and that is so important because people forget to do it or their sons or daughters don't realize they need to be doing this. And so what can change is explained on that sheet. Drug costs can change, doctor networks can change, hospitals are being bought and sold. Things change every year. Prices and deductibles change. You need to pay attention. And so you can call my office, Affordable Medicare Solutions. We're in Suwanee, Georgia. If you want to drive up to exit 111, we're not as far as 273. We're on 85 on 111, not far from here. Or you can call us and we can do a phone and email review. And you can go to our website, amsplans.com. I love doing these talks, and if you have friends that want to come see us, all of my immediate future talks are scheduled there. So if you have a friend that wants to come see me in Dunwoody speak or at Emory University and speak, you can see the dates and times. And I'm happy to have the general public come to a lot of those meetings.